Okay, so diabetic blindness. Basically, I'll just touch on diabetes for a little while and then go right into how it affects your eyes and all that. So we know diabetes when your body is unable to make use of sugar as glucose that is being broken down from the carbohydrates you take in the body. And this happens when either your body isn't producing enough insulin or your body is just not responding to what you have, to insulin you have in the body. And let's see. So basically diabetes weakens and damages blood vessels. When you have excess blood sugar, sustained excess blood sugar, what happens is the vessels, starting with the capillaries, the tiny vessels in the body that carry blood and oxygen around the body to your tissues, they get weakened over time, they get damaged, not just the vessels anyway, it damages the nerves also. But when it comes to the eyes, we focus more on the vessels. And diabetic eye disease, it depends on basically two things anyway. It depends on how long you've been diabetic and how well you are managing the condition. So if you've been diabetic for about 15 years, there is a possibility you start having some changes in your eyes that are indicative of diabetic eye disease. Or there may be subtle changes, but the aim is to just catch them fast. That's the aim of any intervention for diabetic eye disease anyway. You catch it fast so you can take care of it before it wreaks havoc in any way. So this is a diagram of the eye. Can you see my screen?
Yes, we can.
I'd like it. Okay then. So this is an image of the eye. Now this is right here. You have the cornea, you have the lens here. So when light goes into the eyes, it goes through the cornea, through the lens, down into the retina, and then it goes through the optic nerve. This one leads directly to your brain, to the visual cortex at the back of your head. Now what happens? Well, diabetes could affect, yes, it could affect the cornea, it could affect the lens. Basically, when we talk about diabetic blindness, we look at we majorly look at what it does to the back of your eyes. That is the retina, this organ right here. You see the vessels there, the blue, the veins, the red, the arteries. You see the tiny capillaries there, the arterioles, the venules there. So we look at how it is damaging this part of the eye, because this part is very delicate. And any damage done to the retina is basically not reversible, okay? And this is the part where whatever light is being transmitted, that is being transmitted into the eye, this is where the signals are transduced and sent down into the brain. So whatever damage you're having here, it's like zero nada. You do not want to have something like that. So we have something here, is something we can easily take care of. You know, you get to have surgery here, and then if there is a cataract or something, but then we are more focused on this. This is basically what the entirety of the discussion today will be on. So let's see. I've talked about the retina now. Basic bone of the retina. It has is a nerve layer. Is the nervous layer is made entirely of nerves. The retina are made of cones and rods that transmit light into the brain, and then it's supplied with vessels, the arteries and the veins. Those are the ones that carry oxygen, that carry nutrients to that part of the eye to keep it healthy and enable you to see well. So when we talk about this, we are looking at diabetic retinopathy. That's the major eye disease that causes vision loss or visual impairment in a diabetic eye. So while we have different types, we have them non-proliferative, we have it mild, moderate, or severe. When you have something like this, is basically we just watch in the eye clinic, and we don't just watch, we also want you to have your glucose levels optimally managed. like you have them at good levels, you don't have them too high, you follow your care, you follow your management with your physician. Because when it comes to diabetic eye disease, when it comes to diabetic retinopathy, the main aim is to make sure that your sugar levels are well controlled. If they are not well controlled, then it's going to be a big problem to that eye or to those eyes. So just a quick one. When it's still very mild, what happens is, I want you to look here. You see some tiny vessels here. You get some microaneurysms there. What that means is some small pouches of blood just form in the tiny capillaries in the eye. And then also it could leak blood. Eventually it forms and forms and forms, and eventually you get what we have here. You get your eyes leaking fluid, leaking blood, leaking fatty materials into the back of the eye. Now, an healthy eye shouldn't have that in place. An healthy eye should be devoid of leakages or swelling or any infection of any kind. Well, in this scenario, you see this is not healthy because you have blood everywhere there. You have leakages there, you have fatty deposits there, you have some swelling there also. This is what we try to curtail when it comes to diabetic eye disease, when it comes to diabetic retinopathy. So when you have it in the mild form, in the moderate form, we still try to like guard against it. Manage your sugar levels well, make sure they're optimally controlled, and then every other thing will be taken care of. And when you have a severe form of the disease, a very bad form of the disease is what we call proliferative diabetic retinopathy. In this instance, your blood vessels have become so weak and leaky, and blood has leaked well into the back of the eye, that's into the retina. And in this scenario, some of the vessels they get blocked off eventually. So the parts of the eye they are supplying with oxygen, with nutrients, they do not get those supplies anymore. So they die of lack of supply of nutrients and oxygens and all that. And what happens in that kind of scenario is the body now tries to salvage the situation by making some new vessels. Now, these new vessels are abnormal, they are quite fragile, and they burst quite easily. So they leak quite easily. These are parts of what I'm talking about. So we call them neurovascularization. You see those abnormal false vessels there. So with time, they start leaking blood, and they even cause the diabetic retinopathy. That's a very severe form of the disease anyway, so it just worsens it all. And I'm going to go down. Okay, there's another, please give me a moment. Okay, so when that happens, it's a very bad form of the disease. And when that happens, you could even have a large hemorrhage. That's a large leakage of blood in the eye. And when this kind of scenarios happen in the eye, internally, you only see it when you have an eye examination, but externally, it translates to some holes in your vision, some blurry vision, or you get the vision is quite distorted and you're not seeing clearly. In instances like this, you start to notice the reduction in the vision. Some people describe it as a darkening of the vision. So imagine the blood leaking in a major part of the eye. That's the macula, the part you are looking at this slide through, the part here you focus, the pinpoint of your focus, basically, that's the macula. So when you have a big leakage there, that's when it now goes like, oh, I can't see anything at all. That's when we now look at diabetic blindness. Is a very bad thing. Nobody wants to have that. And like I said, the major aim of treatment is just to make sure that your blood sugar levels are well controlled. It's better not to have than to have and now start looking for a way to salvage the situation. So it's much better to make sure that this is not even happening in the first place. So if you're diabetic, just make sure you have an eye examination, a yearly eye exam, or depending on whatever it is your eye care provider tells you, whatever appointments they give you, So I'll just go down now into diabetic macular edema. So you remember what I said about if blood leaks or if fluid leaks from those leaky vessels in the retina, if they are leaking in the part of the eye where your pinpoint focus is on, the macula, that's the part you are looking at this slide through, the part you see with every day when you wake up in the morning and go about your daily activities. If blood leaks into that part of the eye, is like the worst thing ever. It's something you do not want to have. Like I've said, it's very devastating. And when something like that happens, it causes over time, prolonged accumulation like that causes permanent like vision loss or visual impairments that even at the end of the day, treatments like surgery or even injections in the eye may not get you to have optimum vision anymore. It may just help to improve the vision a little. When I mean it may just help to improve the vision a little, it's not like you, if it's bad enough to make you not see anything, then probably the improvement is just well enough to make you just notice a sensation of light. That is something nobody wants to have. It's like that kind of go of light situation. So this is it. So this is the macula. This is what I was trying to explain just now. This is an LDI. If you look at it very well, the macula is supposed to be just a depressed cone in the retina. In this situation, you see it's very blurry here. That's because fluid has leaked very well. You see the volume here. See this, and you see how well swollen it is. Now, in this case, you see all that is going on around here. You see the blood everywhere here. You see the fatty deposits from the swelling here. Like I said, this is something nobody wants to have in their eyes. So emphasis on management, optimal management of your blood sugar. Control it very well. And then another thing that could cause diabetic blindness is cataract. Diabetes basically will cause the lenses of your eyes to swell. In the early stages, it may seem as if you weren't able to read comfortably before, and all of a sudden you're able to read comfortably and all that. It may seem like a blessing in disguise at the early stages, but eventually the blurry vision comes, and then it becomes cloudy and all that, and the diagnosis for cataract comes on. So when something like this happens, it can still be well managed at eventually, but then if there's a cataract there, definitely there's also possibility of having a retinopathy somewhere. And when we have a cataract of this magnitude, sometimes at this stage, we may not really tell how badly it is at the back of the eye until you have that cataract removed. But like I said, you do not want to have, cataract is something you can easily manage with surgery. So it's not much of a concern, but then even before you take care of it surgically, your blood sugar has to be optimum also. So that's that. And then another thing that could be caused by diabetes. Now, basically, cataracts and glaucoma, while it is quite common in older people of about 50 in their fourth, fifth decades of life, for those that have diabetes, it comes faster and they have more risk. That's like a major risk factor for them having these conditions, that's the cataract and the glaucoma. Then also it comes faster and it worsens faster also. So when you are diabetic, it causes your cataracts to, worsen faster and all that. That's something you do not want to have. So like I said, manage your sugar levels well. Optimal management of the diabetes is what matters majorly. So the treatment for the diseases I talked about just now, like we go back to the diabetic retinopathy, when it's still not proliferative, when we don't have those abnormal vessels forming already, good management of the sugar level. And eventually when we have them coming on, we use laser. Eventually you go to a vitreoretinal surgeon who does laser and burns out. Basically, what the laser does is to just burn off those leaky vessels to cause them to stop leaking. But then these treatments also have their own side effects in that a laser treatment could cause you to have several other laser treatments. Same with anti-VGF injection. It's a kind of injection where the scenario where you get injections into the eyes, and it's not one injection, it's you get several in the first few months, and you know, as it progresses or as it gets better, you get like fewer injections. But like I said, you do not want to get into, you don't want it to become this bad. And then we have surgery also. You have cataract, you have glaucoma, you just get them, you get a cataract extraction, you get a glaucoma surgery also, basically a trabeculectomy, and then we have medications also to manage the disease. And like I said earlier, when it comes to macular edema, when it comes to diabetic retinopathy in general, that's when the disease is affecting this part of the eye. Whatever management we are given is to forestall any further damage. It doesn't exactly reverse. You know, like I said, anything here is not reversible. So it's much better to not have it than to have and now start looking for treatment. Well, yes, usually after about 15, 20 years of being diabetic, there's a very high possibility of getting diabetic retinopathy. It's still very good to check in with your primary eye care provider and just to make sure there's nothing going on. And then if anything is on, it's caught on fast, early enough. And that's about that. So we come down to finally, yes. So like I said, yearly eye exams. But then if you definitely have to follow what, this doesn't replace a consultation from your eye care provider. So while you should be having yearly eye exams, if you're certified free of any diabetic eye disease, you also have to keep to whatever appointment your doctor is giving to you. So if you're someone that is already having diabetic retinopathy, you could be told by your physician, by your optometrist, ophthalmologist, they want to see you in every 3 months or every 6 months. You just make sure you keep to appointments. And managing your sugar levels optimally, making sure your A1C levels are very okay. And then we look at blood pressure check also, because blood pressure is also, having diabetes is a risk factor for having hypertension, also high blood pressure, and your cholesterol levels have to be okay also. So lifestyle changes, especially for type 2 diabetes, because for type 1, yes, it's genetic. Type 2, lifestyle changes. When you have it, when you are pre-diabetes, you may not notice these symptoms. You may not even have signs of diabetic retinopathy yet. But then when you are pre-diabetic, it's still better. Lifestyle changes. You go to your doctor. You could get medication. For some people, even a diet is okay to actually like reverse it and all that. And when that happens, it's a very good way of making sure you do not eventually end up within the diabetic spectrum. And even when there is diabetes, you also have to make sure you put lifestyle changes into consideration. So change your lifestyle, become more active, eat healthily, and quit smoking, drink responsibly. I should actually say no alcohol, but but then we are in a world where, well, everybody drinks these days. So I just say drink responsibly, quit smoking, and if you manage your diabetes very well, you got nothing on your eyes, seriously. Major thing is optimum management. I've had people that have had diabetes for like 30 years of their life. We've had juveniles we've had people, elderly persons who have had diabetes since they were very little, teenage years, type 1 and all that. And their eyes are still very okay, simply because they actually manage it well, and they keep to appointments, not just with their eye care providers, but with their physicians also. And another thing is, when it comes to stuff like this, you just have to make sure you're not just have to follow your doctor's advice, basically. And that's about that. So check yourself before you wreck yourself. Thank you. That's about it.
And that's that's very great. Good. Nice one. Yeah, thank you Dr. Mariam Afolabi,